Care and Wellbeing Overview Scrutiny Committee today, Tuesday, the 4th of November. Welcome to our presenters. Just to say that we don't have any plans for a fire alarm. I'm sure you're aware of the procedures, doors over there. First of all, could we have declarations of interest? Members, can they declare any interest, please? Councillor Boynton.
Thank you. I work for Humber NHS, who's a partner in this, but I'm not working directly within the drug and alcohol service, so I'll put it as a non-pecuniary. Okay,
thank you. Oh, sorry. Oh, sorry, Councillor Owen. I realise you're with us online today. Thank you.
Yes, thanks, Chair. Just the usual as Chair of the Health and Wellbeing Board. Thanks very much indeed.
Thank you. Anyone else? No, thank you. Okay, so can I have a proposer for the minutes of the previous meeting, which was held on the 30th of September? Thank you. Councillor Steele, and we've got a seconder for that? Councillor Stewart, thank you very much. Councillor Owen, do you want to introduce the topic today? Thank you.
Thank you, Chair, but I think I'll just pass straight over to, I don't know if Andy's going to kick off on this, but just a comment in reflection, having read the report. Really, I think the importance of the service needs to be highlighted, particularly return, the return on investment, really, the investment in the service, so that social return is really important. And there's some very interesting bits in the report about how more people living in more deprived areas really have lower tolerances sometimes because of their living conditions to drugs and alcohol. And I thought that stood out somewhat in the report, but I won't say any more at this stage, but just hand over to officers to present. Thank you very much, Chair.
Thank you. Councillor Andy Keegan, thank you.
Thank you, Chair. Just to put it in context, this is a slightly delayed report. We were going to bring it earlier in the year, but it explains the impact of addictions, not on only individuals and their lives and their families and their carers and their communities, but its impact upon issues such as crime, issues such as wealth, issues such as the impact upon public services, adult social care, children's social care, public health. So it's a whole system issue, is addictions, that touches everyone in the East Riding, and it needs a partnership system response, not based around prevention. But what I would say is that at the very heart of it is the partnership working, and without that, you can't make it work. It can't be one organisation or one area alone, particularly in a massive rural area like the East Riding, which has very different ways of dealing with addiction issues. So at that point, I'll hand over to Mel. If we could plead, we've got a slight presentation and we've got the one topic on. If we could have 10 minutes just to explain the interconnections of it all. We're not going to go over the full report, but just to bring out some images and some thoughts, just to inform you.
Thank you.
Thank you. So starting with the first slide, this is just to show that our prevalence of drug use in the East Riding and from what we know from our prevalence estimates. So we draw our data from a comprehensive evidence base, and that informs the design and the delivery of our service. Nicotine and alcohol, although they're not necessarily shown on their alcohol, they remain the most harmful drugs that we see frequently used across the East Riding, and they're the ones where we're going to get those typical impacts on our NHS systems and things like that. It's going to be from nicotine and alcohol related harm predominantly. That being said, we have lower levels of harmful alcohol and drug use compared to similar regions. Most of our residents who do have harmful drug or alcohol use don't seek treatment, so our unmet need levels remain high, and they're slightly higher than national average, although throughout the report I will evidence that we've managed to reduce that substantially. And we've done that through an integrated model, which is really about that partnership and working in communities. Next slide, please. So typically the way that people will experience harm is through direct harm themselves from consuming drugs, and that can be accident, illness, injury as a result of those drugs or alcohol. I'll use the term drugs, but I'll combine drugs and alcohol under that term, drugs. And then the wider harms, which is what we most commonly see in our communities and our families, is the indirect harm that's caused by crime, antisocial behaviour and violence. And that varies widely across our area in terms of people's sort of levels of deprivation, where they live geographically, their age, their socio-economic status. So the amount of harm that people will be exposed to and experience will vary widely depending on where they are and their conditions of living. Next slide. So our deliveries focus on prevention and early intervention and harm reduction model. It costs around £350 per person per year across all of our residents in the East Riding, the impact of drug and alcohol harms. We receive significantly lower per capita funding than comparable local authorities. I think we're one of the second lowest in the country currently. Our current spend is around 4.1 million. We subsidise that. Some of that is from the public health grant. Some of that is subsidised from grants and other funds that we've been able to successfully bid for and from trial projects that we've brought in. So that's not a consistent level of spend. Some of that is variable funding that we won't be able to secure in the future. But what this diagram shows is that when people do enter our treatment services, they do very, very well compared to other areas. So we're actually the highest performing treatment service for treatment progress in England currently, and we're at around 67%. Our nearest comparator, so the average for England is 47%, and our nearest comparator is around 58%. So we're about 10% more than better outcomes in terms of people who access our treatment services. So we do very well with very low amounts of money. Next slide. So this is an overview of our service structure. We run on a partnership structure with a number of agencies. Humber NHS Teaching Foundation do our clinical and specialist levels of treatment. We have ADS who run our young people's services, our through care and aftercare service, and those low level interventions, peer support, mutual aid. And then we have NACRA, they're one of our partners who deliver our criminal justice interventions, and that's that transition from prison into the community, people on licence, and working with our colleagues in probation to support people who have got drug and alcohol related offending. And then we also work with a wide range of other partners, including residential rehab providers and inpatient detox providers. And we have bespoke training packages that we offer as well. Next slide. So we've got an integrated delivery model which has run from 2022 onwards, and that's allowed us to do more things at scale. So we work on the premise that there's no wrong door. Wherever anybody accesses our services, they're seen in that moment and they come away with an intervention at that point in time. We don't want people to have to go away and wait 3 weeks and have a phone call and not be ready. We believe that at the point where someone reaches us, that's the moment of crisis where we can make the most impact. So we've worked really hard with our partners to make sure that any point where somebody accesses, they get an intervention in that moment. So we support babies, children and young people who are affected by familial substance use, that might be parental or it might be other adults in the family home, and we offer parenting programmes. We work with our colleagues in maternity, school nursing. We work really closely with them around that family support. Young people are supported to prevent early onset use and also have awareness of substance use issues. So we do that through education programmes that we offer in our school and youth settings, and then we do some more targeted work around those young people with higher needs who might be in contact with things like youth offending or our local authority care. And then adults are supported with a comprehensive range from the early intervention for people who are thinking they might be drinking a little bit too much and developing a small problem and intervening at that point, right through to people who need specialist intervention, residential rehab and clinical treatment, and we can offer a full range comprehensively. Next slide. So we focus heavily on a prevention model, and this is where the partnerships really come in. It's better for us to build resilience in our communities for them to be resistant to that indirect harm from drugs, and that then becomes a deterrent for people developing drug use problems in the first place. So the expense comes at that bottom end where we've got those targeted emergency and crisis services. That's very expensive. So what we aim to do is work with our system partners, to have people treated, as I said, within partner agencies, within the community. It's about upskilling all of our neighbours and really building that community resilience around prevention, and trying to break that intergenerational demand for drug use as well. So we know that if we can get into communities early, young people are less likely to be the next generation of people who are using substances. Next slide. So as sort of mentioned in the paper, we know that there are some groups of people who are likely to experience significant harm from substance use, either directly or indirectly, because of the social groups that they belong to. We refer to those as inclusion health groups, and that's might be people who are from travelling communities, it might be people who are homeless and rough sleeping, people in contact with criminal justice, people involved in sex work, particular groups of young people, and those from LGBTQ+ communities as well. So they're more likely to experience that harm. Not everyone who's in an inclusion health group is a person who uses drugs, but everyone who uses drugs is likely to have an inclusion health need. So we really target our support again around those groups particularly. Next slide. So our outreach services are fully equipped and offer the same range of services that you'd get in any one of our clinics and our hubs. So we are mobile, and we do that on a range of, we have a mobile clinic unit, which I'll talk about, but we also do pop-ups. We also do clinics in community buildings and our partner sites. And there we're able to offer things like screening and assessment. That can be blood work for blood-borne viruses, health checks. We also offer NHS health checks, and a majority of our staff now are able to offer those, and we can offer them to members of the public who are eligible just on a walk-in basis. We do harm reduction, which is about recognising that sometimes people don't want to address their drug use, so the next best thing is to keep them as safe as possible and prevent them having a fatality. So we do that through providing sexual health devices, condoms, contraception, clean needles, and we also dispose of used needles and used works. That keeps them out of our streets and our parks and our community spaces. And then we do overdose prevention as well. We're really proud of our overdose prevention. So we have that in our library services and our customer service centres. So if somebody did overdose in a public space, they'd be able to go into the nearest customer service centre and they'd be able to get naloxone medication and be deployed. The staff are all trained in that. We're working really hard to get that into our leisure services, and then we also want to have it on our bin lorries as well. That's our aspiration, although that's not mentioned in the report. We also offer a hygiene bank, which gives a range of female hygiene products and period products, toiletries, dental products. We give out sun cream and those kind of things to families that can't afford those. And then we have emergency weather response, which can be giving people water and sunscreen and hats, or it can be cold weather response, giving them gloves, socks, those kind of things. And then we have an early warning system as well for drug alerts. Next slide. So this is just to let you know, so this is, I'm sure you've all seen, this is our mobile clinical unit. So we operate on a hub and spoke basis across the region. We have services delivered in reach and outreach via partner settings. So this is just to show you what that looks like. It's not all done via the vehicle. We have outreach teams as well who go out separately. Next slide. So the vehicle is equipped with 2 distinct clinical grade spaces, treatment rooms, and we're equipped with heating, Wi-Fi, running water, electric, and that allows us to do a full range of clinical treatments in there. So we can prescribe medication and administer medication, we can do blood work, we can do blood pressure checks, and we also distribute clean needles and overdose prevention medication from those units as well. It gives us a private space to see somebody. If they're homeless or rough sleeping and they won't come into a clinic, we can still treat them very effectively. We also do things like wound dressing and dental as well from that vehicle. Next slide. So this is just an overview of some of the specialist services that we have. I won't go into a huge amount of detail because obviously you've read the paper, but we offer inpatient and outpatient detoxification services. So that's in a clinical unit or at home with supervision. Same with residential rehabilitation. So that can be within a unit for a period of roughly 12 to 16 weeks, or at home, and then a day programme where somebody would come into the service 5 days a week and be supported. We're unusual in that we're one of the only prescription medicine dependency services in England at the moment that's running. So we work with GP surgeries and have specialist nurses located in GP surgeries, for people who are addicted to prescription medication and pain relief, and we move them into our other services like our pain management services, our exercise referral and our leisure services and social prescribing. That reduces a huge amount of pressure on the NHS for pain medication that's no longer effective for them. We have an intimate partner violence project where we identify people who are both perpetrators and victims of intimate partner violence and domestic violence, and we work with them both separately to support them around their drug and alcohol use and how that contributes. We also have hospital in-reach services, so we're looking at people who wouldn't come to traditional drug and alcohol services but are presenting at A&E with alcohol-related illness and injury. We pick them up, we screen them, and then we support them to come into community treatment services, which is more cost-effective, and it takes that pressure off the hospital. And we can also stop people then, if we can catch them early enough, developing complications like liver cirrhosis and those kind of things. And then we have a whole range of criminal justice services to support people through into the criminal justice system, back out and rehabilitate them to reduce their offending going forwards. Next slide. So we have some specialist services. Again, these are unusual to us. There are in some of the services across England, but we're really proud. So we have a dedicated image and performance enhancing drug service, and we're seeing an increase in that at the moment around not only anabolic steroids and growth hormones, but weight loss medications, fat burning drugs, tanning drugs, and people doing at-home cosmetic injectables and fillers as well. So there's a huge risk around that. This cohort of people don't see themselves as having drug issues. They think they're being really healthy. So we have to use a different model to approach them. So we look at things like cholesterol testing, heart health, and sort of talking about actually you're taking these substances, but do you realise these are the impacts they're having on your body and the risks, particularly around young people. And we have a targeted programme across our schools and colleges and sports academies where we target young people most at risk. Next slide. We also have a dedicated parenting programme. This can be for parents where they use substances or someone within the family home uses substances, or it can also be parents of children who use substances. We cover a range of topics. It's bespoke to that family, so it's not a group session where they go in and they get a one-size-fits-all. It's tailored around that family's need, and it's a 12-week programme that does dedicated family support around mental health, trauma, family conflict, all of those kind of impacts that we would see from substance use pressures. Next slide. And then we have a local drug information alert system. So this is a real-time system that we monitor. And what that does is it allows us to have information on significant incidents such as contaminated drugs that might be in circulation that might pose a risk to people. We monitor that information through real-time surveillance. We get a range of police reports, hospital reports. They come into us, we assess that information and look at risk, and then we can send out warnings, targeted warnings. So it might be a risk to young people and we might put a warning just specifically out to a school. It might be a risk to the general population, and then we'd put out a much wider warning through that real-time digital system. Next slide. And as part of that, we also monitor suicides and drug and alcohol related deaths and near misses as well. So that allows us to target people where there might be something happening. I don't know if you've seen in Hull recently, but they had a weekend where they had 75 people overdose in one weekend from a particular batch of drugs that was circulating in the city centre. We have the same system in place. We work jointly with them on developing those plans. And what that does is we get police reports in when people have had a fatality or a near miss. We look at the circumstances of what's happened in that incident, and then we might convene a panel and bring together a team of specialists. We do that. We aim to do that within 6 hours from us getting the notification to us responding, and that allows us to do targeted work. So that might be putting more overdose medication into hostels if it's something that was affecting homeless people, and putting outreach teams on the ground to go out and spread the word. It might be working with our hospital partners and the police to give them advice on what they might see if they're being called out to incidences and how to respond. So it's really about containment and preventing further risk of harm to the public. Next slide. So we have a mandatory, we have a mandatory combating drugs partnership, which we're currently redesigning, but this is the structure basically. So it reports into the health and wellbeing boards in the Hull and East Riding. We work very closely with our colleagues in Hull. And we also feed into the collaborative boards, and that's a mandatory partnership to meet the requirements of the government's 10-year drug strategy. Next slide. So these are the objectives of the 10-year drug strategy, which are to break supply chains, deliver a world-class treatment and recovery system, and achieve a generational shift in the demand for drugs. We're responsible for some of that, but it is a partnership. So we also work with colleagues in police, health, other agencies to achieve that. Yeah, next slide. And then our partnership outcomes, again, these are set from the national strategy, and then we have a local strategy. It's about reducing drug use, reducing drug-related crime, reducing drug-related deaths and harm, reducing drug supply, and increasing engagement in treatment, and improving those recovery outcomes for people who come into treatment services. We do have some challenges, not everything's perfect. We've recently done some work around our criminal justice service because it's still working on quite an old model, and there's been quite a lot of changes. Nationally, we've got some new prison estates being built, and we've got some changes to probation structures. So we're working with them to make sure that our criminal justice offer is still meeting need and is still fit for purpose. So we're in the middle of an audit and improvement process around that. We've also seen significant changes in our children and families service and in our young people's drug and alcohol service. And as a result of those changes that we led in terms of rebranding that service and changing provider, we know that referrals into the young people's service are lower than we would anticipate. So we've been working on an improvement plan. Many of these actions from the paper being released initially in April to now have been completed over the summer. So we've had that review of criminal justice services. We've rebranded our young people service, and we've done a big campaign of comms into schools, colleges and youth settings around that branding. That branding was led by the young people who access our services and co-produced with them. We've done a targeted programme of training with professionals on how to assess. So again, that no wrong door, you don't have to be a drug and alcohol worker to be able to intervene and spot the signs and know how and when to get support and to refer on. We've got a new website, and that website also has a self-screening and self-referral process on there as well. So parents and families can go on there if they're worried about their young person, do that assessment online, and it'll direct them into the services to get support. We're working with our system partners to identify gaps in provision, and we're responding with targeted provision in areas of need. We've had the comms campaign, as I said, and then 2 weeks ago we held a risk and resilience conference based around all of the harms connected to drug and alcohol use and the causes and effects of that. So we presented to over 70 professionals from the East Riding around trauma-informed care, child exploitation, safeguarding, familial risk, how to refer into services. So everyone who attended that conference was trained in how to do drug and alcohol assessments and when to almost press the panic button, if you like, and where they can get that good quality advice. And we've done a sustained period of work over the summer with our colleagues in education, and we now plan to increase our education offer for children and young people across East Riding in the coming year. And I think that's it. Any questions?
Just to put it in context, as you can see, it's a massive system issue. Many partners, whether it's in the community, whether it's specialist services, whether it's integrating with our colleagues across the council and the police, you can see all the interactions, which makes it a pretty difficult topic to summarise it in one paper. But hopefully that's given you all the avenues that you might want to question.
Thank you so much. I'll open it up to the floor shortly. I just would like to make a comment, if I could, before we start. I thought that was brilliant, that presentation. I really enjoyed it. It was very easy to follow, very easy to understand. I just would like to have had that instead of the original report. The reason I'm saying this, I've really struggled with it, not because it's not really comprehensive, but because I'm really a visual learner and I understand things much better. And I think some of the other members have said this, that when you have the graphs and all the charts that you had there with the colours on, I'm really a lover of that kind of thing. So I had a bit of anxiety when I read this report, not because it's not good, just because I couldn't work out what it meant. And now that you've done that, that's really made it a lot easier. So thank you for that. But just could we consider in future if we could have had that report? before and then you expanded on it, that would be better for me. But thank you for that. So I'll open it up to the floor. We've got Councillor Bibb would like to ask a question.
Thank you, Chair. Firstly, I'd just like to congratulate you on achieving such good outcomes with a limited budget. I think you've done a fantastic job there. But I do have a three-part question about structured treatment. So if you could just confirm what it involves, how easy it is to access structured treatment, and so what are the long-term outcomes? I know we said 67% make substantial progress. Does that mean that they're getting clean and staying clean for a long period?
So structured treatment is it's a catch-all umbrella term effectively. So that's anyone who's had an assessment, and then that assessment will be bespoke to them in terms of their treatment plan. So for some people with a low level of risk, that might just be talking therapies. It might be going to a mutual aid group, so similar to AA groups. It might be having that wraparound support there, and that might be all they need. For other people, it might be medically assisted treatment, so they might go through a period of a reduction in their substance use, because some drugs are quite hard to just stop completely taking straight away. Alcohol, it's very dangerous, so we might do a period of reduction. Then at a safe point, we might intervene with some medication assisted treatment, so some substitute prescribing. Then at a safe point, we might send that person to an inpatient detox or an at-home detox, and then they might go all the way through, have a period of residential rehabilitation, and that's at the point where they're completely drug free, there's no drugs in their system, and they're learning to live without the drug. But it's not as simple as just getting it out of the system. It's that psychological support of how they live without that, and how they manage cravings, emotions that are arising as a result of that, and then they'd return back into the community supported by the treatment service. And we don't kick people out after a time period. We don't say, oh, you've got to be completed within 2 years. We've got people who just need that support ongoing. So we have an aftercare programme, and that's sort of groups that people can come to as many times as they need to. Some people come every day, some people just come now and again just for that bit of support. Everyone has a dedicated key worker who's assigned to them, so it's really about that therapeutic alliance and that intervention with their key worker. So structured treatment is anything from assessment right through to discharge. Where we're looking at those outcomes, so that 67% of outcomes, what that typically is people who've been drug free and they've managed to sustain it for a period of at least 6 months, but we tend to go longer than that, and not relapse and not come back into the service again. So and when although they are sort of on our books, if you like, it means not coming back into that treatment, not needing a formal intervention. They're drug free and they're managing to live a good quality of life.
If I could just go back to one point, is this an easy system to access? Is it easy for people who are addicted or do have problems to get into the system?
Yes, I'd like to think yes. We're trying to make it easier. So as I said, with that outreach and going out to people and meeting them where they are, people can be referred, self-refer. They can refer through the GPs, but it's a universal service, so we never turn anyone away. So at the point of somebody coming through the door, even if we think they don't really have an issue, the fact that they've come through the door, or they've spoken to one of our advisors at an event or at their GP surgery, we will support them. So it's universal. There's no barriers to access, and people can stay as long as they like.
If I could just add to that as well, in terms of the outcomes, quite often if you set outcomes for drug services, it really doesn't help. So in the past, they have been you're either a failure or success unless you've done the treatment. And what we're saying in terms of that's sort of targeted for the individual, it's how they cope with that addiction, how they live with it, how their family lives with it, how it fits in that community. So you need a much broader, richer set of outcome measures about harm reduction rather than just they were a success or they weren't a success. The ultimate one that we get measured on is drug-related deaths. So do people die from it? But that's not something that you're going to have small numbers, but it's not something that really reflects the total number and the impact in a population. And quite often in the past, I would say, not for us, but services have been skewed towards just meeting the targets rather than doing the outreach. So it's easier sometimes to go with the ones you can easily reach rather than the ones you can't find and talk to. Hence why we've been pushed into the inclusion work, which Mel's led and championed for years.
Thank you. Next, we've got Councillor Kristen White.
Thank you, Chair. Morning. So my question's more about the prevention things that you do, especially with children. You said that you go into schools. So I just wondered, how do you get the feedback of how effective that prevention is being? And also things like you said you have a nice new website, but do you actually know, do you look at the analytics, how well it's performing? How many people, for example, access it a month, and is it you would like more or less? And how do you then adjust that to get more people going to that website?
So in terms of our young people's access and our young people's support, we work on 3 levels. So again, we have that universal level where it's open to all of our young people in any youth setting, and we also target young people who are not in education as well. So we try to find them through alternative routes, whether that's through youth settings or whether it's through social care and support in that way. Our education programmes are delivered by qualified drug workers, so they can not only deliver the education, but they can be assessing young people and spotting the signs and picking out young people that they're kind of worried about in that session as well. And then we can follow up with that in terms of one-to-one. So our universal offer is very much around group education. It's tied into the national curriculum. It's bespoke to their age, and the relevancy of that young person. We also, as you've said, have a range of online resources. So we have our website, and yes, we do look at those analytics and we do monitor them. It's only been running for a couple of months, so we would definitely like to get that higher. And as part of that comms campaign that we've been doing is really around promoting that. But it's also interlinked into a web of other resources. So in our Young Healthy Minds website and our Adult Healthy Minds website, which is a council-run resource that directs people around mental health, we've linked back to the drug site through that. We're working with our sexual health colleagues now to have it linked back from sexual health. So people might not present with a drug or alcohol need, they might present with a mental health need or a sexual health need, but we try and link all of those resources so they all feed back to each other. We also have an approach called the MEC approach, which is where people across the East Riding professionals are trained in those resources and how to signpost people to them. So that's distributed as part of that universal offer. Then we have our indicated offer. So indicated is where we know that there are groups of young people who might be using substances. There's something that's kind of linked it. So they've either self-disclosed that they're experimenting, or somebody's told us that they're worried about those young people. And that indicated offer is a little bit more robust. It's a little bit more intense. With our universal offer, what we don't want to do is effectively promote drug use by going, oh, here's all of the information that you will ever need. We have to balance that and not make drugs seem attractive. Whereas that indicated offer, they're young people that we know are actually using substances or in those early stages of risk-taking behaviour and harm. So what we do is we work closely with our colleagues in the Making a Change team, the Edge of Care team, the targeted youth settings as well. So we go out across our youth networks and our youth settings. We use the mobile vehicle, and then we also work with the Our Place vehicle as well. And we'll go and we'll do more intense sessions. They're much more targeted around that harm around that young person. We also support young people who maybe have a key worker in youth offending and they're being seen in youth offending. We'll pair them up with one of our drug workers so that they've already got that really established relationship with their youth offending worker or their teacher's aide or whoever that trusted adult is, and we then support that trusted adult rather than having that young person have to go to a different service. So we aim to meet young people where they are rather than make them come to us and come to clinics. So we're really big on the outreach model, seeing them in spaces where they feel safe and feel supported. And then we've got our targeted offer where they're young people that not necessarily using substances, but they are slightly more at risk. So again, that might be youth offending or things like that. And then we do a mixture of slightly more intense than our universal offer, but not as intense as if we know that a young person's using. And part of that targeted offer is building a relationship with our workers within the service so that it makes a safe space for a young person to disclose if we're not sure, and we can start to sort of build that relationship with them. All of that is monitored, so we have quarterly monitoring processes. We're really robust in our monitoring, so we look at a range of things. We work with schools and they give us feedback. We work with social workers and families around cases, and we support those kind of multi-agency case meetings, those kind of things. But then we also monitor the number of contacts we have with young people, the quality of the service. we do a you said, we did. So we always ask young people to co-produce our sessions and give feedback, and they can fill that in written, or they can also do that online anonymously as well. We've got a chat function there. They can say, I had a terrible session or I had a really good session, and we monitor all of that. That then is collated by the providers and then presented to us quarterly, and we look at that, and we're kind of monitoring for adults and children. As Andy alluded to, it's really difficult to just set a target and say, right, you'll see 100 young people, because that doesn't tell us that those young people have had a good experience and had good quality. So although we have fixed targets that we monitor through the National Treatment Monitoring System and the data, we also work on a balanced scorecard, which is where we can set soft targets, if you like, or qualitative targets, where we can say, actually, we want you to do more events with young people, or we want more assemblies, or we want more open days, and we want that contact. So, you know, sometimes we'll do like a pop-up day where we'll get young people to come in and we'll provide pizzas, and they'll be able to talk about an issue that's concerning them in a specific area or through a youth setting. And all of that feeds into how we then develop and improve the service on an ongoing basis.
Thank you. And I think maybe that's what we wanted to see some of, not in great detail in the report. We need to see that, because otherwise we don't know. And I think, are you spending money well, or are you doing all of these nice glossy things that actually don't work? But you are monitoring it, and then obviously you're then changing and adapting according to that feedback. So it would be really nice if we just had a small section in the report that gave us an example of that quarter, you looked at that feedback, and from that you took this and you're now implementing that. That would have been helpful, I think, to us as councillors, to show it's actually really working in the field, and then how you move on with that. Thank you.
Thank you, councillor. We'll take that back to, in terms of engagement examples and the sort of you said we did, and then the value for money attachment to it. Okay.
Thank you for that. 1 second. Next, we've got Councillor Cousins, I believe, was next.
Hi, thank you very much. I must admit, it sounded incredible. Second lowest funding in the country, greatest outcomes. Brilliant. And I was thinking, oh, it's another rosy spectacled report. And then you came up with the challenges, and I was really pleased to see that. So thank you. That's what I think we're here for. I've got a couple of questions around it, really. One is, how many people, how many residents go through the service on an annual basis? You know, you can have great outcomes if you've only got 3 people, but if you've got 30,000, if you know what I mean. So I was just wondering how many residents are affected by the service.
So our combined totals for adults is currently sitting around 1,274. I've just got the figures in front of me. That's an increase. In 2022, we were seeing around 995 people a year. So we've done a lot of work to get more people in. In the report, I talk about unmet need, and that unmet need is really reflected in that. So historically in the East Riding, unmet need has always been really high, and that's been partly because of the challenges around the geography, the remoteness, and it's really hard to get people on a bus and into a service if they've not got funds to do that and those kind of things. So since 2022, with that integrated model, we've been really focused on taking the service out to people. As a result of that, our unmet need, we've managed to reduce it. So it was in 2022, it was around 87%. At the time of writing this report in April, it was 80%, and it's now 77%. So we are making a dent in that unmet need. How that's calculated is the prevalence of people that we know using substances. So it's the prevalence of we know how they're using substances, and then how many of them access treatment. So a crude example would be if we had 1,000 people that we knew were using opiates, if 600 of them were going into the service and passing through the treatment service, that leaves a 40% unmet need. So that's how we calculate those figures. And then we have a plan around that of how we reduce that unmet need. So part of it is identifying where people are. So case finding, where are they? The next bit of that is kind of meeting them where they are and making that service accessible to them. So as I said, with the vehicle, the mobiles, the pop-ups, having those settings upskilled in communities to meet them. And then the third part of that challenge for us is making treatment comfortable for them, making them want to stay. So if we say to somebody, well, you've got to come to treatment and you've got to stop taking drugs or stop drinking, people won't walk through the door because their identity is really connected to that. So we do that harm reduction work, which is very much around, okay, you might want to continue using heroin, for example, but let's work on you not offending. Let's work on you not being arrested. Let's work on you not having that antisocial behaviour. And then we can show that quality of life is improving for that person. And then that gives us a foot in the door to then start reducing their drug use as a follow on. So that was very long-winded. It was 2 questions in one. But in terms of for our population, I think the unmet need nationally is only slightly lower than us. So it's around 54% for drugs, and it's around 72%, I think, for alcohol. So we have made that reduction, and as it's reduced nationally, it's also reduced for us as well. So for a demographic of our and geography of our area, we do really well in terms of that, although it does remain high and we would like to get it lower.
I could just add that impacts on things like supplementary grants, because we seem to be doing well, we get lower grants.
Yeah.
Which is problematic.
So I'd had that on all the time. As I suppose my follow-up question was that how is the funding package arranged? It seems to be common for East Yorkshire to be the lowest, the second lowest, the third lowest, the lowest quarter of funding in the country, which is sad. And particularly if rurality payments are reduced as well, it gets worse. So how is the funding package negotiated, and what can we do as recommendations to improve that, to allow better meeting the needs, particularly of that unmet need, if you like?
I'm sure Andy will answer a little bit more about how it's negotiated, but we bring in a lot of external funding. We look for research opportunities, we look for trial projects that have funding attached to them, and we try to implement them in the East Riding. So things like the prescription medicine service and the alcohol care team are examples of where we've managed to go out and source funding and bring that in. The intimate partner violence funding, we've managed to go out and bid for that through sort of the work that we do and bring that in, which is, again, it's a double-edged sword, because it's good in the short term but it's not sustainable long term. So once we put these services in place, we then have to look at how we sustain them going forwards. In terms of, as Andy's sort of highlighted, across the East Riding, if you look at our average for the whole of the East Riding, we look like we're doing really, really well. If you took that on a ward level, so if you look at somewhere like Bridlington South, we know that per head of the population who are using substances there, they have significantly higher levels of harm that they will experience than inner city areas like Hull, in terms of just the sheer number of people, if we made that relative comparison. But that's kind of averaged out in terms of you then comparing it to other areas of the East Riding where there's very, very low levels of drug and alcohol use, and there's no kind of, so the average on balance, we're always in the green, and it's really difficult to unpick that and to evidence that actually we have really significant need, particularly around those inclusion health groups, those areas where people need more entrenched support. And it's how we use the money that we have to make sure everybody gets equity across the whole of the East Riding, but then we also divert it to the places that need it more, because their challenges are greater, and the way that we do that with such little funding is around that community partnerships and sharing that resource. But then, as Andy says, we're a victim of our own success, because it looks like we're doing really well, and actually I could double our spend and still do more. So yeah.
But I can just come on to that in terms of proportionate universalism. You want to provide a universal service, but you don't have enough to do that. So you really then try and focus on the higher risk target areas where you're going to get the most benefit. And that's our permanent trade-off in public health. In terms of the negotiation, this is an ongoing discussion with Department of Health, Office for Health Improvement and Disparities, which we have on a regular basis about our grant funding levels. There will be changes, we believe, this autumn in terms of the public health. Public health is funded purely through grants. There is no draw on council funding. Everything comes from either the public health grant or supplementary grants, and that's clearly the case for for drugs and alcohol services. As I say, we live and we live or don't live based on whether we can get grants in or not, and the performance of them. And if you do not perform, you often lose the grant or have it cut substantially. What we think is going to happen, and again, this is just what's been told in discussions, is that the supplementary grants for public health may be rolled into one grant. So we'd have just one set grant for public health. I'm hoping it's a 3-year deal, and then that gives us longer term. But it might be a 1-year deal. That's what we've been living off previously. The problem there is that the fundamental calculation for the public health grant was based on spend back in 2012-13 when we were very, very low, and that's just been carried on. That bit has to raise from where we are to the average has never happened. So we've always been playing catch up. So we could get a 3-year settlement, which would be excellent, but the danger would be it'll still be probably in the bottom 4 or 5 in England rather than the bottom 2. But that's a major improvement for us. But it does mean that proportional universalism, how much you target, how much you do general, that calculation just becomes harder and harder. And again, but I would say that the success is recognised nationally and regionally, and we get asked the exact question, how do you do it with so little money? Which doesn't actually help some of our colleagues. Because then it's, well, they can do it for half the amount, we'll give you half the amount.
Thank you. That was very comprehensive. Yeah, I mean, yeah, we look after or I look after a ward that probably is in one of your lower use areas, and people are always surprised to hear that drugs are in every community and hide away from it in the lovely leafy Pocklington Provincial. We have asked the police to split out their statistics on violence, for example, into sexual violence and domestic abuse. And I feel that probably would bring the messaging somewhat closer to home in some of those areas. I didn't know whether you thought that might be an improvement. And Rob, I didn't know whether there was a recommendation around commending the team on their sort of proactively embracing innovation, but that it has an impact on ongoing funding, and whether we can look at talking to the ministers in charge about being successful shouldn't mean a reduction in funding. It should mean that it stays stable. And I do believe that we should have much longer than a 3-year settlement for longevity. Thank you.
Thank you, Councillor Cousins. I think Councillor Kristen, might you want to wiggle on that one?
Yes, please, Chair. Just because we were saying about the lowest funded, and we get that as well in children and young people, and Councillor Aitken does a great job lobbying government for more money for SEND. So I just wondered if we could ask Councillor Owen if he could maybe do similar and lobby government for more money in this area. Might not be successful because again, Councillor Aitken's trying hard, but not always going to get the money. But if we don't try, we don't get. And as they say, the wheel that squeaks the loudest usually gets the oil. So if we could squeak a bit more, you never know. Thank you.
Councillor Owen, did you want to respond? We're putting you on the spot
I
now.
will do. No problem with the sentiment there, but I think even if we look at sort of children's services, we've been shouting for 25 years, as have our MPs. Often it's working behind the scenes quietly, using the evidence that we've got to try and make change, but happy to shout from the rooftops. My experience over the years is it doesn't make a lot of difference other than a few headlines in the press for a couple of days, but happy to take that on board. But I'll continue working with Andy behind the scenes as best we can on this. Thank you, Chair.
Thank you, Councillor Owen. Andy?
Thank you, Chair. I think a part of our argument to government is the wider impact of addictions has upon all different parts of society. And you mentioned there about crime, particularly domestic violence. And I don't know if Mel, you want to mention something about the perpetrator funding and PCC.
Yeah, so we managed to successfully do a bid with the Home Office where we brought in a substantial amount of funding to run a pilot project over a 2-year period around perpetrator violence and intimate partner violence, as I sort of mentioned in the report. And what that project does is it works with people who use substances who then use that as a means to be violent, and we do a lot of work. So we've connected with our domestic violence agencies and we work with them around that intervention for the perpetrator to give them better ways of coping that doesn't result in violence, and to address their drug use concurrently. But we also then work with their families around them being victims of that violence and how we support them. Violence against women and girls has therefore become a key focus for the Police and Crime Commissioner, which on the surface feels like a really good thing. However, we receive a minimal amount of donation from the Police and Crime Commissioner. And again, I would point out that out of the 4 local authorities in the region, we again have significantly lower. We get around £50,000 a quarter less than other local authorities. But the Police and Crime Commissioner's Office have now decided that they want that funding to continue that domestic violence programme beyond the Home Office funding period, and for us to pick that work up. We also heavily subsidise that work anyway with our other sort of initiatives within the service, again, that using that economies of scale to share that resource. And that on the horizon is going to be a significant challenge for us, because it's going to pull the money that we currently use for criminal justice services away from that and divert it into domestic violence services. And obviously we'd love to be able to do both, but we can't run 2 significant pieces of work with one set of funding that has previously been allocated. So hence part of the work that we're doing on our criminal justice service now, to look at if we can make efficiencies, if we can look at sharing that resource. But it is currently a risk for us in terms of that negotiation with the Police and Crime Commissioner's Office of what that might look like next year in terms of that funding once the Home Office funding ends.
Thank you. Councillor Gill.
Thank you, Chair, and thank you for the presentation. I work with a lot of Duke of Edinburgh youngsters, and recently they're saying about the concern amount of vapes that are used in the secondary schools, and they tell me it's nearly everybody. It worries me, because obviously, you know, so I'd like to know sort of percentage wise how often you go into the schools to, you know, and share that information. Just my second point is the juice bars. Sounds a brilliant idea. I wasn't aware of it until today. Again, where are they? Are they in schools or are they in towns and communities? Thank you.
So in terms of vapes, that is a significant concern for us. In terms of our education packages, we don't specifically just talk about vapes or talk about drugs. We talk about a range of harms, and we know that vapes are a way of not leading to drug use, but it's an early entry into experimenting with risk-taking behaviour. So my colleague Angela actually leads on, we've got a separate work stream that is particularly around smoking cessation and vaping. And we've done a huge piece of work again over the summer. We've developed 2 educational resources. One is a video resource to actually show in schools to young people, and that talks about how vapes are seemingly harmless, but then it goes on to talk about the harms. We also know that vapes can be linked to young people being exploited, so we kind of start to get young people age appropriately considering that it might be more than just using the vape. It might be wider harms. Again, there's indirect harms. So that video resource has been produced and it's in the final stages of sign off now, and that's going to then be shown in all of our schools and colleges across the East Riding as part of the regular national curriculum health and social care lessons. So that's going to be there. That's also available to our drug education team that then go into schools. We don't have a regular, so some schools we go in and we see them all. We have a week where we'll do every class in the school in a week, and then we'll come back 6 months later and do the same exercise again. Some schools we have a drug worker that's in there once a week and then runs assemblies and classes as part of that. So it depends on the school and the need in the school as to how often we're there, but it's open to all of our schools and it's free, so there's no charge for them to do that. And all of our drug workers are trained around smoking cessation and vaping, and they do use that, and we assess for that in terms of our risk. In terms of your second question on the juice bar, so that's in all of our college and sports academies at the moment. So we try and do that at least monthly with the vehicle. So that goes in to all of the sports academies. You might often see it on Flemingate, outside the college on Flemingate. It's there, and it goes up to Bridlington. And it's there for a full day. And as part of that, we do targeted sessions again. So we go into classroom sessions with sports academy students and wider students as well, but we sort of target those ones around sport because we know that that's where the risk is greatest. And they'll do maybe a session in the morning that's actually an education session, but then the team and the vehicle are there for a full day, and then students can drop in and out, and we pick them up and we have those conversations around iPads and image and performance enhancing drugs. But we also then, it allows us to have those wider conversations as well around sexual health and other drug use as well. So definitely it's in all of our colleges. We're not in every single school. Some schools don't want to have that discussion around iPads. They want to have the discussion around other substances, but it's a core offer. We've done training with all of our East Riding leisure services staff. So the juice bar goes to all of the leisure services staff as part of their core development programme, and they've all been trained in iPad use and again being able to give advice, spot the signs. And we've also started working with a couple of private gyms. They're much more reluctant to work with us private gyms because some of their business model is around people using steroids and image and performance enhancing drugs. So yeah, allegedly. So that's much harder for us to, but again, we're working with some individual personal trainers. So we're finding different routes in. The juice bar also operates a live chat. So one night a week, it's there's an advisor who's online, and that's well promoted, and people will drop into that as well and access information online.
Just a small thing, not all the towns have leisure centres and things. I wondered if maybe you could include libraries, because, you know, as I say, there's maybe not as much problems in my ward as Bridlington and Goole, etc. But it would be nice to include libraries, please. Thank you.
Yeah, we can definitely do that. The libraries have been a really big supporter in terms of the overdose prevention medication and having that life-saving around people overdosing in public spaces. So anything else that we can roll out to them would be more than keen to do.
Just to add to some of the questions about is it seen as illicit drug use, the service is targeting? Well, we talked then about prescription addiction, and people who do not regard themselves as addicted but are addicted to painkillers or other drugs. And then we've managed to set up systems to actually try to pick that up, deal with it. But it is something that's a lot more prevalent and that's understood nationally, and people do not see it as an issue. Do you want to say something?
Yeah, so that project came about because there's open prescribing data, so we can look at different prescription medications and how frequently those medications are prescribed. And we know that in sort of coastal towns, particularly where people retire in their later years, there's high levels of prescription medication, particularly around pain. What we also know, though, is that particularly opiate-based GABA and Z drug, they're types of pain medication, those types of pain medication are only effective for a short period of time, and then they actually start to cause you pain. So you become stuck in a cycle of needing more prescribing, and it's not really helping, and your quality of life deteriorates. GPs don't have the time to sort of respond to that and to treat that. And again, people don't see themselves as having dependency issues because they're doing what they've been advised medically by medical professionals. They're compliant. They're not going out and using illicit substances, so they don't see themselves in that same way. And for that group of people, it wouldn't be appropriate to ask them to come into clinics and those kind of things. So again, we have our specialist nurses in there, and we've done a huge amount of work to bring our prescribing levels down. We're currently in 13 GP surgeries along the coast. We'd love to be in all of the GP surgeries across the East Riding, but again, we've got a very small amount of funding for that currently out of our budget, and if we had more funding, we would love to be in every single GP surgery, and we'd love our colleagues in the NHS to supplement that funding, because they obviously see the end benefit in the saving of the prescribing costs, whereas for us it's about improving that quality of life for people.
Thank you. I'm conscious of two people wanting a wiggle. If you could make it very, very brief, because we have got people in the queue. Thank you. Sorry, Councillor Babe.
Yeah, thank you. I will be very quick. It's just around the prescription medications. Is antidepressant use considered an addiction? Because a lot of people seem to use it long term. And is there a pathway to try and get people off antidepressants?
So they're not typically, although a person would experience some withdrawal with antidepressants, they're not typically considered in the same way. It's more that people, so the way that an antidepressant works is that it tops up existing chemicals within somebody's body that are already there, as opposed to pain relief medications, which are adding something extra in. So for some people, that long-term use is appropriate. However, we have a really strong social prescribing model, which also looks at when people have their medication reviews, is it just about giving someone a pill and that's it? Or do we include them in going to our leisure services? Do we bring them into our community groups, our kind of, so that social connection, which for some people there is a real clinical need for them to be on a lifelong pathway of antidepressant medication, but for other people it's a short-term thing, maybe because they're experiencing trauma or they've had a difficult period in their life. And we do look at how, with that social prescribing model, we support people to come off those medications and integrate. Probably it's worth mentioning as well about dual diagnosis. So we know that there's a cohort of people who have a mental health need and then they use drugs, whether illicit or prescription drugs, to self-medicate, and that ends with them having a dual diagnosis. And that's really difficult to unpick, because we don't really know whether it was the drug use that caused the mental health issue, or if they were already predisposed to the mental health issue, and that then led to the drug use. So we've worked really hard with our colleagues in the ICB and Humber Trust over the last 2 years to develop a dual diagnosis policy, which is now in place and is working really well. Historically, what we used to find was that people would go to a mental health service and they'd say, oh, I use drugs, and they'd say, well, come back when you've stopped using drugs, and that wasn't attainable for that person. Or they'd go to the drug service and they'd say, I've got a mental health issue, and they'd say, oh well, we can't address that because we're not equipped to address that. We can address your drug use but not your mental health issue. So they were kind of stuck between a rock and a hard place, and they were trapped in that using those substances because they were effectively self-medicating. So we're really pleased that we've been able to develop that policy, and again, we now have much stronger pathways, so people shouldn't fall through the gaps between those services.
Thank you. Councillor Kristen White.
Yeah, I think mine's more of a statement. It was Melanie, you said that with prescription drugs, that the GPs, they don't have the time. I can't remember the end bit, but basically they don't have the time to monitor them what's going on, which I've got to say is actually totally unacceptable, because I actually think that is because of the outcome. If the outcome was that prescribed drugs by GPs ended in overdose and death, we would not be happy with that outcome. We're only saying it's okay because the outcome probably is not a high death rate, I'm assuming. So just wanted to make it known that I think it's totally unacceptable that GPs do not monitor the effects of the prescription drugs that they actually give out to patients. Because if you were a drug dealer and people were overdosing, we'd all be in absolute uproar.
I think I probably just need to clarify on that. So I think what happens is GPs prescribe for people and with their presenting need, and there are processes around medication reviews. I think the bit that the GPs don't have the time to do is to address where somebody's got a dependency and doing that specialist work around that dependency, and that's where we can intervene. So the alternative would be that GPs say to someone, oh, this medication is no longer working for you, and stop that, and then we're putting people effectively through quite a traumatic process of withdrawing. So it's about how we support GPs to do that specialist work around behaviour change, addiction, and integrating people to living without the drugs.
Because inevitably it all comes down to money and who's footing the bill.
Thank you. I'm sure we could spend a long, long time on this subject. I'm just conscious, very conscious of time. Is that okay? Okay, so I just got a couple of questions, if that's okay. So I wanted to set the scene from a councillor point of view. My ward is Billington North Ward. I don't have a huge percentage of people that come to me with drug issues or problems, but if I was to be at the college, which is very close to my ward, and I was chatting to a young person, could you talk me through the process? If someone came up to me as a counsellor and said, Councillor Phoenix, I've got a real problem, I don't know what to do, I'm dependent on a substance, what is the communication pathway for? I don't just want to say go to this website, because I wouldn't feel I was doing that, offering the right service. So could you talk me through the actual process and how long it would be before that person could be getting the right treatment? Thank you.
So again, there's a number of ways that people can refer or self-refer. We have a huge amount of resources, which I think again is about making those available to ward counsellors. So we have printed information that doesn't include websites, and we have that available to offer as well. And we have a range of ways that people can be seen very quickly. So ideally, if someone didn't want to go onto the website, that is the quickest way is to go on the website, because it covers a 24/7 referral process, if you like. People can refer by telephone, you can refer by email into the service. We have nationally target is to see somebody within 3 weeks of making contact. We aim to see somebody in less than 7 days, and we aim to really, in working sort of time, see people within 24 hours. So from first contact, if somebody telephoned, they would have a brief intervention on the phone, and that would start that process and part of that intervention is, does the person want to come into a service? Do they want us to go to them? Where's the nearest place where we can pick them up as quickly as possible and access that? So there is a range of access methods, as I said, website, email, telephone, we've got printed material, we've got live web chats, we've got online self-assessments to try and mean that if somebody is in crisis at 10 o'clock in the evening, they can come in that way. We also have a range of our system partners that are referring to us. So if somebody rang the crisis team for mental health but disclosed that they were having concerns about drug use, that would trigger a referral into us. If somebody approached a teacher, a social worker, all of the schools know how to refer into the service. We've normally got our workers there. So it's challenging because we've got such a big geography. We can't have a worker in sort of every area. But the other side to that as well is if you were concerned about antisocial behaviour, drug use, drug-related crime in the area, we also have an online reporting system that's done through the Council Achieve system. So you can find that under the council services. If you search for drugs, it comes up, and you can fill that in with concerns, and we can also pick people up that way as well. And that feeds into that real-time warning and alert system as well. So sometimes we get members of the public will say, I'm really concerned about, I think there's drug dealing on this street corner near my house, there's something happening. They're not entirely sure what it is, but that comes through to us and we pass that information on. So that might be through to the regional organised crime unit, it might be the Force Intelligence Bureau, it might be through the drugs partnership itself. So we can pass that on as well and try and be as robust as possible in our sort of points of contact.
Thank you. That would be really useful if we could have some links, because we can't always hold everything in our heads. But I think my problem is that what I would have normally done is I would have gone through group office, it would have sent an email, they would send it on to somebody else, it would go around for a while, and then eventually I might get a response. So the quickest, as you've said, the link to the website is crucial, isn't it, by the sound of it? But I've never heard of this. So if members could be, if you could share that information, that would be really helpful. Thank you. Councillor Boynton.
Thank you. I'm going to disappoint people because I've got 2 questions and a quick comment, but I'll try and make them as fast as I can. First one was from Councillor Bibb right at the beginning, where he was asking about people being able to access the service, and you were confident that people were. I suppose we've asked similar questions at this committee previously. Are we confident people are able to access the service? The answer's been yes. But then from the recent CQC report, it obviously shows that there are issues. So it's just doubling down on that one, really, making sure you are 100% confident that, yeah.
I think, again, when we're talking about that unmet need, so as I highlighted with unmet need, it's where people are known to us and we can find them and we can access them. We can make it really easy for them to come in. There will always be challenges for us in terms of those hidden populations, hence us having that inclusion health model, which is really looking at how we go out and find people. We also know that there's people who, even when we find them, they experience a huge amount of barriers to accessing service. And again, that model is very significantly around removing those barriers. So whilst I'm confident at the point that we can make contact with people, it's as easy as we can make it. I do also acknowledge that there are people that are hidden from us, and we do a lot of work around people who are being trafficked, people who are being exploited, who it's not easy for them to access, and those kind of things. So we are definitely aware of that as an ongoing challenge.
And I think we all appreciate it's a particular difficult demographic that you're working with to access, really.
If I could just come back on your question there, Councillor. So in terms of understanding that need, some of that need is expressed and people want something. Some of it's hidden away and people aren't expressing it. And the one I would probably push to would be alcohol and the increase in alcohol use post-COVID. People not realising the impact it's having and the addiction of it. Sitting at home watching whichever television program you like for as long as you like, but that alcohol level creeping up and not understanding it until it becomes a problem. So I would say, are we meeting all the need? No, because some of it's not expressed. And if we had even all the resources we'd want, some people still wouldn't want to come forward because they wouldn't see themselves as actually needing it.
Second to the third question. Just in regards to the residential detoxification service, I was aware previously, you had Buckrose Road at Brid, you had Millview at Castle Hill. I've kind of lost track of that service. So I suppose the question is, have we got an inpatient detoxification service within Hull and East Riding? Bearing in mind, we know that outcomes are better for people locally.
No is the short answer. We use a facility at Doncaster. The reason being is that there are 2 types of models that you can use for inpatient detoxification. One is a medically managed service, which is the preferable gold standard model that we aim to use. There are only 7 providers now in the UK that have a medically managed model. So that's a consultant-led service where there's always a medical consultant on site 24/7. And then there are medically monitored services where there are consultants for a portion of the day, and then it's other sort of staff, whether that's approved or non-medical prescribers on the site. So what we've done historically, as those units have closed and those facilities have closed down, what we've done is we've taken a block contract with a medically managed provider, which means that at any given point in time we have 2 bed spaces that we can utilise and access, and we aim for around 90% occupancy, so we've always got somebody in one of those facilities. And that's for our really complex cases where people need to have that consultant led. They might experience some harm if they're unsupervised in their withdrawal and that detoxification process. We then supplement that with spot purchasing. So there are other units such as Chapman Barker, which is in Manchester, which we can supplement with if somebody needs an emergency detoxification and we can't get that through the local hospital, Hull Royal Infirmary, we'll put them through that in terms of spot purchasing, although most of the time that doesn't happen because we've got those bed spaces and that occupancy to access. And then around that is that medically monitored. So for some people, it would be more suitable for them to be detoxed at home and have a daily member of staff going in and visiting. So that we would love to have everybody in a facility that's in our area, but given the level and quality that we aim to go for in terms of that being consultant led, Doncaster is the nearest facility for us now currently.
Chair, can I make a recommendation from that then? And I've got to be careful because I do work with Humber, but like I say, I don't work within the drugs and alcohol services. But like I said, if we're aware the outcomes are usually better if people are close to home, they could be visited, near family, so on and so forth. You have got Humber NHS there that historically has done that service. You talked about the spot purchase that we all know from budgetary requirements cost a lot of money. I think there's a good key point there for us to scrutinise that decision at a later date, and maybe for Councillor Owen or Kim to look at as well for us. And
Andy?
So thank you, Councillor. So in terms of trying to develop the market for a local medically led treatment service as part of our market shaping for the next contract.
Just to add to that, we have explored that, and we worked in partnership with the local authority in Hull and the public health team, and it wasn't cost effective for Humber at the time that we looked at that. So that was about 2 years ago when we did look at that as an option. It's something we would be keen to have. Obviously, it's better, but just it's not listed in the paper. But again, in terms of those outcomes, around 4% of our patients go through an inpatient detox, and then again, the national average is 2% of patients. So we are again doing well with limited resource, but ideally we'd love something closer to the home. Yeah.
Well, Chair, we've heard ideally close to home. It's probably a good item for us to.
Could we do that, Tom? Rob. Sorry, Rob. Okay, thank you.
And very quick final question is, Melanie, you mentioned the 3 key partner agencies, Humber and the 2 others, one which works in prisons, but you did mention agency and partnership. Now, when agency is mentioned, my head sees money lying out, and bearing in mind our budgets that Councillor Owen will be well aware of. Has consideration been given to bringing those services in-house within East Riding? Again, historically, I know we've just had the CQC report, but historically, better outcomes, lower cost.
We have considered that. We had a model previously with our young people service that was provided in-house, and what we found with that was over the years it eroded and it became less of a young people's treatment service and became absorbed into core business effectively, and that became really difficult for us. In terms of our contracts, we have one contract, which is with Humber Foundation Trust, and then they subcontract through that partnership to NACRA and those other agencies. So in terms of the cost effectiveness for us, it's one block payment in a block contract, and any additional costs are then absorbed by Humber. But again, we're always open to looking at that model and looking at what our capabilities are in terms of income generation as well.
Again, possibly another thing for us to scrutinise that we've just heard that ideally you would like it to be in house is what I heard there, but it got eroded over time with pressures. So again, it's maybe something to scrutinise, and maybe something for Kim and Councillor Owen maybe to keep an eye on, so that it doesn't get eroded into different services as pressures arrive.
Yeah, you got that, Rob. Thank you. Thank you, Councillor Boynton. We've got Councillor Cantrell next, patiently waiting. Thank you.
Thank you. Going back to the health inclusion vehicle, which sounds really good. However, it does regularly come to Cottingham Market, and I believe it goes out to other places. But I'm not certain that people really understand what it's there for. So it's there, and I've been myself with some of my friends, and I know that you can go and get your blood pressure done and maybe a blood test, but there's so much out there with leaflets about drugs, sexual health, all sorts of things, that I'm not sure it's really being utilised in certain places.
Yeah, and I think that's resource pressure. So that vehicle is all things to our service. So we do some targeted work. So as we've said about the juice bar, it's used for that. We use it for targeted youth work in the evenings and going out into youth settings. We use it for our general community offer as well. We then use it for targeted work around homeless hostels. So depending on the location, will depend on what staff are on that vehicle on that day. We literally had a very small pot of funding, and we were like, what could we do with this funding that would capitalise and get the furthest reach for the service? And that's where that kind of clinical unit came from. But as I said, it's on different days, it's doing different things, and that's been a real challenge for us. Because ideally you'd have more vehicles, more branding of different things. So I do take your point, and I'm not sure how we have like billboards and things like that, and we publicise where it's going to be and what its functions are on council media, but I'm not sure. It's just we use it for everything that we possibly can to get as much value out of it as possible.
Just add in terms of the inclusion element of it as well, and that being available for people to come on their own terms. So for example, someone who's homeless might see it that they wouldn't want to go to the homeless van with drugs issues. They'd want to just go and chat with everybody else. So I think it's a question of how you make it available. It's not really there as a general health purpose for, that's the NHS. It's there for that inclusion health, and that's what we're trying to target and make it seem attractive, available without stigmatizing.
So could there maybe be a focus? So for example, for people to come along, get the blood pressure checked. I know that it's there, but I do see people just walking past, and I know that there's usually 2 members of staff on there.
Yeah, and as Andy sort of says, we don't ever turn anybody away. So things like blood pressure checks, there are specific people that we really want to check their blood pressure, and then there is the worried well general public who we would never turn away because it gives us that foot in the door, that conversation, but then they're not really our target demographic of what we're looking for. So it's again that fine line balance between seeing lots of people that we don't really need to see because they're well and it's a community service, which again falls under a different remit, and having that targeted work. So we try and be all things to all people to get people through that door, and that is a real challenge for us, but I do take your point.
Thank you. Councillor Bayram.
Sorry, I was wondering if it would be a good idea to have a glossary of all these acronyms and that are being used, because there was quite a few when they did the slides up and I really didn't know what they meant. And if we could have it all written down so we could bring it each meeting, so then we'd know what was going on.
Do we have that in the report or not? We do.
There is on the back of the report, yeah, but I can also provide additional clarification if needed.
Yeah, I agree that it is often we spend as members a lot of time working out what the speak is. So although I accept that, you know, there is this terminology that's used, we do sort of then have to run through the paper to find out. But yeah, it is. I thought it was in there. Thank you, Andy.
Completely agree, Chair. In terms of we're talking about inclusion, we need to make it as inclusive as possible.
Yeah.
So we guarantee we'll do glossaries, but we'll try and keep it in the body of the text.
Yeah, that's brilliant. Thank you.
And now we don't have paper copies. We have to look on here, so you're scrolling backwards and forwards all the time, and it's driving you mad in the end.
Thank you. Councillor Blakeston.
Thank you, Chair. I kind of wanted to dive into the area of performance management because that's of interest to me, but I am mindful of time.
Okay.
So I'd just kind of like to ask a couple of very high level questions, if I may. I understand the use of the balanced scorecard and the KPIs. So I wondered whether those KPIs and balanced scorecards are shared across all your system partners. So they've got the kind of end-to-end visibility. And in terms of driving continuous improvement, do you use kind of insights from issues that you're picking up from lived experience or ward councillors or whoever, to drive that continuous improvement, which may update or create new KPIs, and how do you gain confidence into whether you've got the right KPIs, whether they're measuring the right things? I know there's quite a lot of questions there, but hopefully that's not going to take too long. Thank you.
So we have access to a huge amount of data, which is generic public health data, which tells us just about our general populations in terms of their age, demographics, where they're located. We then have specific dashboards and databases that are specifically around drug and alcohol related harm. As part of my role, I also work with MAPA. I sit on the Criminal Justice Board. I work with some of the violence groups that are set by the Police and Crime Commissioner. So we have access to that police data as well. And we have a dedicated person within our team that sits in an analyst group, so they can pull all of those sources of data that we get through things like the Community Safety Partnership. And then we have the National Treatment Monitoring System. So everybody who goes through treatment has an individual tracker, and we can see where they end up. And that gives us lots and lots of data, huge amounts of data. We drill that down into the balanced scorecard, and we compare that, because that's all quantitative, it's all number data. We drill that down and we combine that with the qualitative stuff, so the lived experience groups that we have, our stakeholder feedback, our quarterly monitoring meetings with the providers, the drugs, so the Combating Drugs Partnership, so that's all shared with our stakeholders through that, and we've got compile a quarterly summary that's shared with our partners such as police and health partners, and where they can make an impact and what impacts we're having. And those forums give us the feedback then for them to say, oh, I've seen this, or I've seen that, or this is what's happening in our area. We also do a lot of temperature checking with other partner agencies such as our pharmacies and things like that. So again, those community agencies that see people on the ground, and we respond to that feedback on a continuous basis. So again, that goes into the balanced scorecard. So a recent example of that would be where we've had people who've suggested that the injection equipment that that is provided to them, they would like a broader range of that injection equipment. So we've looked at that. We've done a cost effectiveness of what it would it cost us any more to provide a different range of equipment. We don't think it will. So then when responding to that, because that's come through that feedback loop from a pharmacy. So that's just one example. Another example where we respond to that would be the community rehabilitation programme. So previously, there was a school of thought for a number of years where we had to send people away. We had to take them out of their environment, away from all of their contacts, and put them somewhere completely neutral for 3 months. And that was the only way for people to get better. And we realised that was excluding a huge amount of people who have pets, who have families, who have children, who can't go away for 3 months. So we developed that community day rehabilitation programme in response to that feedback, and that's been really successful for us because it gives us a whole new layer of people who can be supported in treatment as a response to them saying this wasn't suitable, the previous treatment offer wasn't suitable. So to be as succinct as possible, yes, we monitor a huge range of data. We share that with partners. We compare that qualitative feedback and quantitative data, and we're continuously monitoring the service. We meet with the provider at minimum quarterly for a formal monitoring performance management meeting, but we also meet with them at least once a week, sort of online Teams calls, regular chats, just to keep that real-time improvement going for them.
Yeah, thank you. That's really encouraging. I've chaired something called the Driffield Healthy Town Project in, obviously, Driffield for the last 4 or 5 years, working with stakeholders across healthcare provision and social prescribing, including the police and including the local schools, looking at specific health issues in our town, obviously wider than what we're talking about today. But working with the ICB, we've got some real access and almost be able to go down to street level in terms of health issues and also antisocial behaviour and things like that. Where we tend to then struggle is putting in services or responses to address those issues. And we have got opportunity in Driffield for accessing quite substantial funding. But quite often we can't use that funding because we can't find anywhere to find somebody to deliver that service. So it'd be quite interesting just to talk to you outside of this perhaps about that data-led approach to healthcare. And, you know, because we've already heard across the East Riding, there's lots of different challenges depending whether you're in a large town or in a more rural environment. So I'd be interested in having a sort of a follow-up conversation. Thank you, Chair.
Andy.
Thank you, Councillor. KPIs and performance management absolutely central to the strategy. Where are we now? How do we know? Where do we want to be? How are we getting there? Absolutely need that information. And the key bit is the partnership, understanding people's agendas. So we get KPIs set nationally in terms of national drug schemes, national partnership work. Also, behind our funding, you have to hit these targets, so you have to measure them. That always doesn't lead you in the right direction. It can sometimes limit it. And then, as you say, local voices, particularly in the future, we'll be looking at neighbourhood plans, neighbourhood health plans, where that would fit, and how you tie what might be a national target to a local need and local assets is absolutely key. And I think balancing local need, local assets, local innovation with those national targets is the sort of challenge for us, particularly if you're on short-term targets all the time. You know, you're looking at a year ahead or next 6 months. You're not looking at 5-year prevention. Let's develop. Let's work something out. You're into no. We'll just do the ones we're told to do. But we try to avoid that as much as possible.
Yeah, thank you for that. We've got our final person, Councillor Walker. So I'm conscious of some of you might need to have a bit of a break if you do, because we're nearly at the end, I think. So if you need to just escape for a minute, that's fine. But otherwise, we've got Councillor Walker.
Thank you, Chair. I've been called much worse. What a great report, especially for joint working and celebrating it. It's clear that you've achieved a great deal with an unfairly restricted funding pattern. On that subject of jointness, wondered if you were aware of the Community Alcohol Partnership, which brings together neighbourhood policing, the supermarket managers, licensing from East Riding as well, specifically looking to reduce things like proxy purchasing for children, specifically targeting children and young people and their use of alcohol. And the way that they reach into schools and produce an awful lot of literature, posters and the like. Is there an opportunity there to, because it works, I think it's Home Office funding, but it's quite different from their clear hold build issues locally. And I wondered if there was a way in which you and they could jointly work. They bring a great deal of online printed and youth focused materials.
Yes, community alcohol partnerships are a challenge for us in public health. They're actually funded by the alcohol industry as part of their social corporate responsibility. So we do acknowledge them. We do try to work with them in the spirit of partnership as much as possible. But we also have to balance that with ethically working with a partner that then profits from targeting marketing of alcohol products. So it is a challenge for us. One of my team is part of that community alcohol partnership and works with that team. We also work with the police who sit on that team. So there is support and they do a lot of good work around not selling to underage people and things like that. We do support them in the production of some of the resources. Again, some of the resources probably fall outside of the standard of resources that we would produce. So we work to the UN Convention of Drug Education Standards in terms of public health. So all of our resources and materials have to be sort of to that standard. And some community alcohol partnership, because they're local initiatives, there'll be a local lead. So some of those resources are not necessarily to that same standard. So we tread a fine line between trying to support and mutually acknowledge, but not overly bringing them in, because we have to be careful about a lot of the information, a lot of the data, a lot of the things that we have and share is restricted, and therefore bringing in people who are representatives of the alcohol industry is a conflict of interest for us.
Splendid. Yes, Andy, please.
Yeah, absolutely, as Mel says, it's a balance. We're obviously very pragmatic in this riding, and we're not going to turn down funding, but then we need to be aware of different agendas and where those agendas could cause us more problems in the future, and particularly looking at commercial determinants of health. We're fully aware that there are players with different agendas, and we're part of that. So it would be naive for us not to engage, but then it would be naive for us to expect our agenda is going to be met, and that's where it's an ongoing discussion with them.
Indeed it is, and our involvement through East Riding's licensing department too. Finally, if I may, Chair, just because that crossed over a great deal to children and young people, do you feel that this might be an opportunity to work jointly with the Children and Young People subcommittee here? Perhaps on a joint, could this be an item for a joint venture with them?
Yeah, I was thinking that actually, as we were going through all the presentations. So I don't know what you think about that, Rob.
Yes, it's a suggestion you can consider again in January when you determine next year's work programme.
I think we can put that as a recommendation. Oh, a wiggle from Councillor Kristen White.
Yeah, just on that, if it wasn't possible for us to do it jointly, could we make, as this committee, a recommendation that it gets put on the work programme, or at least gets considered?
Are we allowed to do that?
Yeah, I mean, you can do both. We'll put it forward as a suggestion jointly first, and then if it doesn't get picked up, I mean, it's again at this stage, it's only a suggestion. It's just something to consider in January.
Is that okay? Yeah. Oh, Andy.
Just to assure the committee that Mel spent most of the summer going around various committees, talking to them, including, do you want to say the head teacher?
Yeah, so as part of sort of the briefing for this paper, we went out to the JLTs for adults and children. We went out to SEND education groups, early help teams, head teachers. So we have tried to really use not only this paper, but that promoting that rebranding of the children's service. We've done a heavy campaign across the summer to take that out to as many places as possible.
You've done a brilliant job. Thank you. So if that's okay with everyone, I think we'd like to sort of wrap it up, but I'm just conscious that Kim, would you like to say anything? Are you? No, you're okay. That's fine. And Jonathan, have you got anything you'd like to add before we close?
No, nothing. I thought it was a superb report, and it's been a really, really good debate and discussion. So thanks very much to Mel for pulling that together. Really good stuff. Some good stuff come out of it, which I'll pick up as we've gone along and take forward. So thanks very much indeed, Chair.
Thank you, Councillor Owen. Councillor Boynton, you want something to add?
So just before we break, for item 4, I just wanted to bring something that it might be useful for having Kim and Councillor Owen here if they're able to stay following that.
Did you hear that, both?
Yes.
Yes,
I did. I wasn't planning to, but I will do. Yes.
Okay, thank you. So, Rob, do you want to give us a summary?
Thank you, Madam Chair. So there was a recommendation about some lobbying activity around the funding, particularly around how the East Ride may be at detriment. I would pick up slightly there. At the last meeting, we wrote a similar letter to the government about deficit funding for the East Riding, which you both had sight of. So there may be some opportunity to review that and see if wait for a reply on that. Again, it's a similar story across different issues, isn't it? But once we've got a reply for that, that'll obviously be shared for members. And then there was 3 items suggested for further scrutiny around local detox centre, rehabilitation centre, young bringing that young person's offer in-house, and then the joint scrutiny activity between ourselves and SIPOSC. Again, I would reiterate, and it is getting to this point of the year, all the suggestions you make now are just suggestions. Once you come to the workshops in January, you can choose to do something different or amend it if you like, but this is the time to get those items in for the next year's work programme.
Anyone else want to add anything? No, are we okay? Well, I'd like to say thank you very much to both. It's been very, very interesting. I'm so much more reassured now. I heard you speak so well, and thank you so much for your presentation. You've done a lot of work, and I think we're all a bit more comfortable than we were before we started. So that's brilliant. Thank you. I think have we done, or do you just want to come back to the next item? Yeah. Does anyone want a break? Should we have a quick break? 5-10 minutes, or?
I don't know how long the rest of the meeting will be, though.
It's probably only 10 minutes to go. So how are we? You want to just carry on? Yeah. Okay, we'll carry on.
Okay, thank you, Madam Chair. So there's 2 points I'd just like to bring up under the work programme. I've detailed them briefly on the back of your notes there. So the first is there's been a request for an item to come to the next meeting of scrutiny in December around the redesign of the adult inpatient services for Humber Teaching Foundation Trust. I understand this shouldn't be too significant of an item given what we've got already, but it is time sensitive. So if members would be happy to bring that for that meeting. Okay. Secondly, members will be familiar. We are scheduled on the work programme an item on prevention for this meeting. We've spoken to Andy and the chair, and we are just looking to defer that very briefly. And I don't know if Andy wanted to come in any more on that.
The reason behind it, there's a lot of work going on currently that's been changed, possibly in response to the CQC inspection as well. So we wanted to not open up discussions that we couldn't give you clear answers for. So there's an ongoing piece of work in the council around a prevention strategy, prevention policies, prevention activities, and that responding again to recent inspections as well. So I think there's an overall piece of information, piece of work that if we'd been talking about it today, you would probably give me more questions and answers, but it'll be comprehensive.
Do we have an idea of when we might be able to see it? I'm putting you on the spot.
I need to talk to my CLT colleagues first before committing.
May I suggest then that we defer this consideration for the next meeting then, and we can pick it up in December as where we put it?
It's only because I'm so excited about it. I would like it to be sooner rather than later, but I do take your point. It's better to have the more detailed, comprehensive report, I'm sure. But yeah, we'll pick it up at the next meeting. Yeah. Anything else?
Just quickly touch on the forward plan, and then maybe we can get on to any other discussion. So just below that on your notes, you'll find the learning disability big plan, which I understand follows on from the learning disability strategy. So this is a renewal of that strategy due to be considered by Cabinet on the 13th of January. You'll find some details there as what was included in the forward plan submission. So that's for members to decide if they'd like to pull that in for pre-decision scrutiny.
I think as we mentioned, my only concern was I do like to try and keep each committee to 2 items, and I think this will be the third on that day. But I am conscious of the fact we need to look at it. So if it was a short presentation, I would be happy. So I don't know what other people think about that. Anyone else want to commit? No. Councillor Boynton's looking curious.
I got lost on it. So this is the adult inpatient redesign that'll be deferred. I don't know if I got lost on that, sorry.
So there's 2 suggestions for additional items. So the first is the adult inpatient redesign for December. And then what I just mentioned was the learning disability big plan. That's a council pre-decision item. That would be in January.
I mean, again, working in Humber in the adult inpatients, I think the adult inpatient redesign is quite a major thing, and probably there'll be a lot of questions and interest in it, really. So I can imagine it being quite a big item.
That was my only concern. Could Councillor Owen maybe give us an insight into how much time this would involve? No.
The answer is no. I haven't got a clue how much time it may involve. No.
Okay.
I don't know if Kim can reflect on this or not. I don't know.
No, all it was, we were trying to plan, how many items we'd have on the agenda for that day, and we didn't want to sort of be swamped. So we just wondered how much time it would involve, but that's fine if you're not sure. Councillor Boynton, I think you wanted to say something. Oh,
I was just going to say, so it's pre-consultation at the moment. So it's if you were to see it now, it would sort of be an outline of the service rather than a deep dive as such.
Did you want to come in? No.
No, again, I can imagine it one that members would be very interested in. I can imagine it taking a bit of time, even though it's just a pre-consultation, really.
You need to see it, though.
Oh yeah, no, we definitely need to see it. It was just about whether we put it into that particular date. That was all. So we're happy with that. Yeah. Oh, Councillor Gill.
Maybe if we started at 9:30 that particular day. I know I appreciate a few have got further to come, but it just might give us that extra half hour, I don't know.
Councillor Christy White?
Yeah, Rob, can you make sure that they actually give us everything in the paperwork so that we're not coming and then if there's 3 items, we're listening to 3 presentations and trying to process 3 lots of different topics in 3 hours and then ask the questions that anything that they're coming here to summarize it and give us it in a nutshell, and then we can question because we've had all the information beforehand, not trying to digest it as we go.
Yes.
Right, is that okay? Yeah, okay. Councillor Boynton.
Thank you. I just wanted to talk about the CQC report and kind of the processes that have happened. So you remember at last health scrutiny, we mentioned the CQC report. A few members weren't necessarily aware of it, but it had only just come out. Now, a similar report's happened for Children's Send Service previously. That report went to Children's Service. They met more regularly and they scrutinised the issues, shall we say, and actually it worked to really good effect. They had to meet more, but there was a good outcome for the Special Educational Needs Service. My concern is that we've got a ready-made scrutiny committee here, and there appears to be conversations to set up a different CQC committee rather than it sitting in its natural home, which is this committee. I can imagine actually some members from here probably feeling a bit disappointed, really, if that's moving on without any consultation with this committee in the first place, and the recommendation going to full council to set up a new committee. I suppose I just wanted to hear people's views. Having listened to the scrutiny today of drug and alcohol services, I think everyone's got a good grasp on the health and social care. Personally, I don't see a need for a different committee. If it's worked well in the past with children's services, it can potentially work well again with us. However, I'm happy to be in the minority if members are minded it should go elsewhere.
I'm just conscious of the fact that it's not actually on the agenda. I don't know if we can we allowed to discuss this? It's fine if we can. I'm just checking.
This committee wouldn't have any power to change the recommendation that's been made to the from the Overview Management Committee. That will be discussed at council next Wednesday. So you may want to discuss it, but ultimately it's a matter to be decided at council. And at that council meeting, you'll receive a breakdown of the terms of reference for that committee and all the rest of it. So generally, you're not working with the full information.
But I suppose the frustration is that this committee is being completely bypassed. How many members knew they was going to Overview and Scrutiny Committee? I bet not many whatsoever. Surely we should have had that option to have a say, put our views forward, be involved, bearing in mind it's the natural home. I feel very strongly that we've just been absolutely bypassed on this matter, really.
Does anyone want to say anything about that? Councillor Bibb.
I actually disagree in a way. I think it's a good idea to have a separate committee, and I think there can be a big crossover. I'm sure many members of this committee will be invited to sit on the new committee, but it's just such an important issue that I think it'd be very difficult to fit into our work plan. Yeah, it's something that deserves to be standalone, but that's just my opinion, and that'll be decided by full council anyway.
Thank you. Councillor Walker.
Just very briefly, Chair, I echo your point. It's not on the agenda. And even though there may be time to discuss it, this is an item what was looked at by Overview Management, making a recommendation to full council, and that's the place for it. That's where the debate should happen.
Yeah, I take your point, Councillor Boynton. I think maybe with hindsight, we should have had a discussion about this. I think it's all happened rather quickly. Everything has been, from my perspective, sort of, there have been discussions behind the scenes, and maybe members have not been aware of what was happening. It was voted on at OMC, and my understanding was at OMC it was a recommendation. My other understanding was that members do get to vote on that at full council. Is that correct?
Yes, so it would be amendment to the Constitution. So yes.
Yeah. So that was my understanding. So I was under the impression that if people didn't agree with it, they could vote against it.
And again, I'm happy to be in the minority, and some we win some, we lose some. I think there's just a question of almost a professional courtesy for it to come to the at least committee to be aware of it. Surely.
I take your point. Thank you. Anything else? Councillor Cousins.
Sorry, I can't let Councillor Boynton sit on his own with this. I completely agree with what you've said. I think this is the committee that should have been scrutinising it. I realise it's going to full council, and we all will have our say at full council. There will be a reduction in the size of this committee and its ability to scrutinise properly. I just think it's a very sad state of affairs that this recommendation has been made. It's been sent to central government. It's been acknowledged by the minister in charge at central government and come back straight over our heads. I don't think that's democratic, and I think it's an appalling process that's been followed.
Thank you both. I think anything else? Oh, Councillor Berry. The actual process, do you mean the decision, or we have, sorry.
On what specifically? Around this new committee, Councillor Bayram? So it's on the agenda for council, not this meeting. So council next Wednesday, that's where it's on the agenda.
You will get the agenda at the normal time.
Have to get it.
Yeah. You will get it. Yeah, the decision will be taken at full council. That is, and it will be on the agenda, which will come out today. Correct? Yeah. Okay. I think that concludes.